intervention and progress in South Sudan. So we will be talking about the long journey from a paper base to where we are now, and how the improvement in reporting and in maturity of health information system have supported South Sudan, or helped South Sudan achieve some significant level of investment, both from our partners, the in-country partners, and the donor community. So it will be a very short brief, and I will ask the one controlling the slide to be moving. We'll move next slides. Yeah, basically our presentation will have about 8 subunits, and the last number 8 is just acknowledgement. This work was supported by so many partners and colleagues within Ministry of Health. We did the case study last year. We brought together several partners in country to sit together and develop this case study. So I'll be, introducing the background, the genesis of health information systems, starting from Sudan to now South Sudan, and how the fragmentations of the paper-based system really made life so hard compared to our digitized systems now using a DHIS2. I will also, in this case study, we only focus on only 3 major disease programs that are well structured and well supported by the partners. So the data completions rate is accurate, and we use such disease programs to come up with this case study. We'll also be looking at the lesson learned and the key recommendations from here. Move next. Yeah, as I first recognized Nora and Ayub, we started a long journey of trying to restructure the fragmented health information system in the country, right away from 2011 when we got independent in July 9th. We were part of the Sudan, and everybody is aware in Africa that South Sudan has been at war for a very long time. So everything was so fragile, including the healthcare system. So the central database system rested in Sudan, was in Sudan, and everything was actually centralized until 2011 when we came to Juba. We started documenting our data on papers, a journey that marked with a lot of data loss, workload, papers, and the high cost of printing of these HMIS things. So we move away from paper simply because there are a lot of issues. So as of 2012, the reporting rate, the reporting rate in this of all data sets were about 43% compared to 2022 when it was 77%. Our thresholds is up to 90%. I think we are going to achieve it maybe by 2026, the end of 2026, we'll be able now to achieve that much. In 2010, we started the piloting, and we started with DHIS 1.4, and that's 1.4 really helped us a lot. Nora is here on the call. She spent much of her time developing 1.4 in South Sudan and moved all of us states and was supervising the development of this DHIS 1.4. So the data presented here is from TB, HIV, and malaria, where we highlight key interventions and the system used to collect this data. So the journey will be massive, and we'll see how we have moved out from there. Can we go next? Yeah. So just allowed me to give you a little bit background of healthcare system in the country. Our system is a 4-tier systems where we have a tertiary level that is consisted of all teaching hospital and referral facilities in the country. We also have secondary level that comprised of state hospitals and the county, the prime healthcare centers and units, plus other non-conventional naming of the facilities like the clinic in case of humanitarian operation in the country. They set up some clinics across the POCs and their own camps, and they name them the way they want. Although the package remain the same with the package that is being provided at the primary health care level. So we also have a community health programs. We call it Boomer Health Initiative, where the strategy was developed in 2017 and rolled out as a catalyst to speed up the health service delivery to the community. After the study done, we chose around 44% of the population is within 5 kilometers radius, and 56 are outside. So, Boomer Health Initiative was initiated by the then Minister of Health, and it is now the flagship of the Minister of Health to deliver the healthcare services to the community. In terms of the management, we have three levels of management. And these are semi-autonomous. They are totally independent from one another. So we have a national minister of health, that is the overall body tasked to do the policy formulations and the rest. We have the state ministries of health that report to the council of ministers at the state level. The boss of the healthcare sector at that level is a minister that report to the governor at the state level. We have county health department, which is actually the lowest unit of healthcare administrations. The county health department is headed by the county medical officer, who reports to the commissioner. So all these have a technical link, but administratively they report to different administrative linkages. So that governance of the healthcare management is facing some challenges, but still we are yet to determine exactly what is the economic impact or cost effectiveness of centralizing the healthcare management. These are some of the things that we are moving forward. But as per now, this is the brief health system structures that I can present it to you. Move next. Isabella, can we go
Pendula,
next?
Pendula. Yeah, thanks.
All right. Yeah. So this is a journey that we undertook for that period of time. The pre 2010 was dominated by the fragmented data systems, where the NGOs and UN agencies carry on their own surveys. There were no centralized systems. The indicators were not harmonized. There was no standardized data collection tool to collect the data. So the result was system fragmentations and a lot of decisions being taken without following what the data is saying. And the government was also not having a control over the data. So the data was just flowing to a certain area. It is collected by the partners using their own systems. They report to their headquarters without government having a control over it. So the decisions were most of the decisions were affected because there was no data. Things to do with resource prioritizations, thing to do with the planning, like the number of beds that can be taken to that hospital, because you do not know the total inpatients, the outpatients that coming to visit during the day, and the expansion of the health facility. So it was really a very serious periods that the Minister of Health undergone. So from 2010 up to 20, a little bit late 2012, we started with the piloting of the DHIS 1.4. We developed some standard operating procedures to support the data, collections, specifying who should report to who, when should we collect the data, and how should it be collected. So that pilot was carried out in Upper Nile region, where Jonglei and Upper Nile states are located, and the pilot was successful. there were some computers stationed at the national level where we are now at the policy planning. There's a big hall down was used for computers. It was a computer lab where the hard copies were brought from state. The facility report to the county health department. The county health department takes the report to the state. Now the state takes report to the National Minister of Health, where they are going entered into the DHIS 1.4. So most of the challenge was that the 1.4 was offline version, mostly using the Microsoft Access, and there were a lot of things, but at that level was far better than the paper base. So the system was somehow centralized, the data was integrated, and we were able now to have a very little control over the data at that time. So in 2017 up to 2018, we got some support from the Global Fund in Grand Cycle 6, GC6, to try to pilot the DHIS2. That was really a defining movement. Dr. Ayub is here, was one of the very first consultants that we recruited to come and establish the systems, customize all reporting forms in the DHIS2. And we managed to acquire a little bit the high percentage of reporting rate, and also some decisions were totally informed, and you could imagine the most reliable funding that South Sudan rely on is the Global Fund funding, which is actually a database funding. So you have to get correct data in the system for how many people are on ART currently, how many people are on the first line, how many people have tuberculosis, how much quantity of medicines that need to be procured, what should go to the health system strengthening, the cross-cutting issues. So all these things are based on the data. And the allocation keep improving from when we were paper-based to somehow digitized 1.0, DHIS 1.4 to DHIS 2. So the allocation was improving. To now, as we speak, we got around 129. Last year, we got 141. Unfortunately, this year dropped a little bit because of the global financial landscape. And this happened because our system has improved and the data that we have is accurate and is used for decision making. We also use that data currently for expansion. We will be able now to get the data, and we know this facility, the number of people coming to visit this facility is huge, and therefore we need to expand. So without this system, it was actually going to be very, very difficult. So with the joining of South Sudan, joining ADC in 2023, we had a lot of things. ADC supported us in a number of things, and we interpret some systems. Currently, we have ETBR, the case-based tuberculosis management systems, where we are managing the patients for TB. We have electronic management information system for logistics management. So was supported by the Global Fund through Supply Foundations. We also integrated human resource information systems and EIDSR. So we are moving away now, trying to move away from AWAS to EIDSR. That is now linked to DHIS2. Another good example of digital maturity or DHIS2 maturity is the use of this system to do a mass campaign in 2023, where we got an award from Alliance for Malaria Prevention. So we distributed 5.7 million nets to the community using DHIS2, which resulted to giving us 9.5 million net this year. So the AMF bought for us 9.5, and we are still using DHIS2 now to do a mass campaign in all over the states, targeting around 16 million people. So we move from a paper-based to a digital systems that came with a lot of improvement and a lot of success stories, trying to get a lot of resources with regard to all the improvement that we have. Can we move next, Pandula? Yes. So as of 2024, because this data we stopped at 2024, Malaria is one of the diseases that is, killing us. South Sudan is one of the countries with a high burden of malaria. Uh, you know, Given the fact that we have a lot of rainfalls, almost 6 to 7 months in a year, and we have been having a flooding consecutively for the last 5 years. So malaria become a number one killer in South Sudan, where we have a total of 64% of all OPD visits and account to 30% of inpatient admission. So the death at the facility is just 45%. But this is actually lower because in South Sudan, most of mortality are happening outside the health facility. So these are just the deaths that have been reported to the facility. But whatever happening in the community is not recorded. And that's why you see like South Sudan globally is not seen to have a high burden of malaria. We are contributing 1.1%, which some of the partners or donors are criticizing us that you are not a high burden country because you are contributing a very low percentage. But because some of our data are either not recorded to the facility or taken to the private facilities. Last year, when we did subnational tailoring, we found the treatment seeking rate at the public facility was only 6%. So it means 94% of the malaria cases are taken care of at the private sector. And now we don't have control over the private sector data because of lack of resources to do that, lack of framework to govern the private data. So we are trying to bring all this to make sure that the data is there in the systems and is integrated. Can we move next? Yeah, you could see the trends of the reporting rate starting from 2020 up to 2024, where reached around 60% of the reporting rate, almost 10 times, starting from a 10% to almost 60%. You could see this came with the rolling out of DHIS2 from a county to the health facility. Like now, you don't follow the reporting channel of from the facility to the county, county to the state, state to the national. No, you just report directly from the health facility. We distributed tablet to the health facility, and those facilities are reporting directly, especially the private healthcare centers and the hospital. So we are left with the Boomer Health Initiative and the primary healthcare unit that continue to report through the county health department. So this investment in digital, I mean, in DHIS2 by providing tablets, training the M&Es at the subnational levels have actually improved the coverage. And you could see the number of cases reached per year, as you see from the other slides, I mean, the graph at the right-hand side, has a bit improved. Around 7.3 million people were covered, and the positivity rate, we got around 5.9 million people were positive. And these are those that came to the health facility. So we came up with another idea of coming up with a community digital reporting systems where we develop an apps to roll it out. Is now being piloted by Malek Consortium in Northern Bargazal State. And we are next year we are planning to roll it out. So it's a system used by the community health workers, people with very low technological literacy, those that have not gone to school so much. So we develop a very simple tool to be used by these people targeting malaria at the community level. So the reporting from 2026 onward will a little bit improve because we are going to be reporting the malaria cases in the community through the Boomer Health initiatives systems. Move next. Yeah. So you could also see the trends of malaria admission by age groups. The graph at the left hand side is above 5, which is eldest, and at the right hand side is under 5. You could see both from 2021, the admission due to malaria is still high, both among under 5 and above 5. And there are some years of fluctuations, going up and down. Sometimes due to lack of quality data, some interventions like in 2023, there was mass campaign for LLI distributions, which might have actually contributed to the low admissions in that year. But as time goes, these mosquito nets are warning out. People are not using them. Wrong use of these. So the admissions due to malaria keep coming back. But this year we are doing mass campaign. If we were to do this another analysis by next year on malaria, we'll see maybe it might have gone down a little bit. Move next. Oh, this is geographic heat maps for malaria incident per year. The data is extracted from SNT. You know, and you look at the crude rate, you could just see like we are all okay. Most of the counties are okay. Like you just get a crude, you could see like only 100, only 10 per 1,000 that are affected by by malaria, and you could see across. Now, but when you come to all presumed cases, you just say all presumed cases are being reported. This is incident adjusted. You will just find in 2023, 2024, there are some malaria cases, especially in Abia area in the northern part of the country. But when you come to the third row, where all cases of malaria are assumed to be tested and the reporting rate improve. In 2023, you could see most areas are having a lot of cases, going from 450 per 1,000 populations. And when you assume that all cases of malaria, okay, are reported, and all cases of malaria are treated at the public health facility, all right, and the treatment seeking rates improves, you could see most countries are in red. All right. So this was a subnational tailoring that we did for malaria, and you could see the whole burden is changing. So the most of areas become malaria better, with the exception of northern Upper Nile, which sometimes get dry at most cases, and most of that area is on the highland, so it's not that affected by flooding. So this I'm bringing this to show you how the improvement in the data reporting and the maturity of the system is help us now to create some heat map that will communicate an information quickly to the decision makers to really see how we can be approaching things. Like if we are saying all cases are treated at the public health facility, the area, the country will be malaria burden of almost 450 per 1,000. But because most of cases are being treated at the public health facility and they are not in the system, you just see the first two rows of maps that we are okay from 2021 up to 2024. Can we go next, Condola? Yeah, this is the peak, the pattern and the peak. So South Sudan mostly the peak started in July and the curve start sloping down in November. So between July and November, you get a lot of malaria cases all over the country, but for all year 2021, 22, 2023. So it gives us like during the last mile delivery of malaria and the quantifications, you have to know that between July and November, you need to have a good stock of anti-malarial all over the country because you are expecting to have more malaria cases in the country from July to October, then November now start declining. So you could just see the lowest incidences were observed between January up to somewhere June. And if you could see this area, this is a dry season period in the country. Unlike this year where rains started in March, we are going to see how the trend is going to change next year. So if we are to do the same analysis next year, we'll also see maybe the peak may change from April to somewhere in November or December. Next, please. So ANC coverage and diagnostic gap. You see there is a gap at IPT3. Most of our women don't go for antenatal care coverage, and you could see that when they come for the first time, the third time they don't come, and based on the WHO recommendations, Panta, I mean IPT 3 and above is recommended, and ANC 4 and above. These are actually recommended, but it started from 2020, you could see it is very low at 8,000, 15,000. You move up to 2024, it reaches to nearly 150,000 at ANC visits for IPT1, and it dropped. You could see the pink color is IPT3. It's still very, very, very low, and it despite being low, it keeps improving as we move to the next year. Like starting from 2021, there are a lot of things that were done. We move up to 2024. So going to 2025, 2026, you could see the number of mothers taking, or the uptake of IPT 3 will a little bit improve. And this is actually improvement in health information system. So the decline sometimes because of shortage, maybe the up reagents for testings and the rest are not on, and maybe the supplies are not enough to reach there. So the positivity rate versus microscopic, you could see where the dark, I don't know this color is RDT, and the other one is microscopy. So you find most of our facilities are using RDT simply because almost 70% of the facilities are PACUs that use RDTs, and very few facilities use microscopy. And you could see those tested by microscopy and those tested by RDT. So there is that variations, and still from year it keeps improving from 2020 up to 2021. Like for example, the RDT test in 2020 was around 20,000. We moved to up to 2024. We have 2.5 million people tested using RDT, which is a very good improvement in reporting rate. Can we move next? Yeah, for HIV, although South Sudan never done aid indicator survey, we are relying on a spectrum projections supported by UNAIDS, and that gave a target of 91,000 by the end of GC7, and we still have a lot of work to do. Up to now, we have more than, as of December, around 87,000 people were on ads, just a little bit improved up to December 2025. And the viral load suppressions is around 85%. And the retention has a little bit improved as the next projection is coming out in May. It's not yet out now. We still have a draft, but there is a significant decline in new infections, and the number of people living with HIV keeps reducing. And up to now, we are between 150,000 to 182,000 in that range, but we always take the lower bounds for our reporting purpose. So the EID positive rate is 2.2%, which need us actually to work hard to go below 1%, which is a target. So it requires a lot of work at the PMTCT, although South Sudan now is moving to eliminations like EMTCT, but still we are still getting around 2.3%. So this reporting it shows there is a little bit improvement in the systems, in the reporting for HIV, and we are planning to use the same system now next year if Global Fund allowed us to do a targeted HIV indicator survey. So we are using the same system now to do sentinel site monitoring, the ANC sentinel site monitoring for HIV, and those are the figures that are used to feed into the spectrum to give us the projection for those that are on Earth, those that are living with HIV, and those whose viral load has been suppressed. Next, Fandula. Yeah, so this is the growth and the linkage to care. So you could see the fluctuations, like in 2023, drop down somewhere, it goes high and it drop down and goes up. So these are a lot of factors, thing to do with lost follow up, like the referral system wasn't well done. You could see someone is a lost follow up in one facility, in another facility is a new on art. So people keep changing. And that needs now to strengthen the referral systems and come up with a tracker, where we can track the people that are tested here, either using a biometric or using a unique ID, and see how best we can, collaborate with the Ministry of Interior that is in charge of issuing of the national ID to ensure that those that have ID or those who do not have ID should have access to ID to help us track, the people. So we are still not there, but we are planning to be there. So we are calling out for the well wishes to support us to really see how best we can harmonize. So like the positivity and linkage trends over time is going up and down, and that's really not good. You could see now the trends of TX current is going up steady, but it's start declining. You could see in 2025 is coming down. This because this report was done in November. I remember November before December. So some reports were not, reported yet, and in December it actually goes higher than this. But all in all, the curve is declining, and we are following up on that. Move next. Yes, so this is viral load suppressions and PMTCT outcome. The viral load suppressions reached 88%, that is in 2024, with 85 testing coverage, reflecting a strong retention and lab system. So infant positivity declined sharply, as you could see, from 4.5, 4.85, 4.9 likely in 2022 to 2.3 in 2024. So it actually demonstrating that the PMTCT program is working hard, but it's still the 2.2 positivity of exposed infant is still high compared to the other countries. And South Sudan wanted to eliminate that, bring it down to almost less than 1% or so. We move next. Yeah, so this is EID coverage and versus reporting rate. So this is the reporting trend in from 2020 to 2024. It improved as you could see the curve is steady, is going up, it's upward trend. Although we could see there are some declines and rise simply because of issues of reporting and. The system was transitioning, like most of HIV system was being managed by IntraHealth, and they were transitioning to ICAP. So that transitions made us to lose some data in the process, and later on maybe report it. And you remember the transition always have a lot of challenges. Some facilities were still using paper based, and interoperability of the two systems that are being used was still not completed. Like ICAP cloned the DHIS2, and they were using that to capture the data, which jeopardized the facility reporting to the national database. So the EID coverage improved through better ANC integrations with the PMTCT, and still we are calling for more integration so that we get improved PMTCT management at the health facility. Move next. Yeah, with the tuberculosis, we up to 2024, there were around 64 gene experts. Currently, more 17 gene experts have been added, and that is going to improve the tuberculosis, the TB detection in at the facility. So we're also planning to integrate the TB screening into Boomer Health initiative that will also improve the reporting. So around 229 cases of MDR were detected in 2024, and we achieve around 85% treatment success rate, which is a very good indications. And in 2018, the ETBR was integrated into DHIS2. It's actually a fully system integrated into the system. So we are into DHIS2. So we are getting data on quarterly basis, in the DHIS2, and that was a real achievement, and it has really helped us manage the data and use the data for decision making at a very, very, very high level of the health sector management. Move next. So case notifications is bacteriological TB confirmed and TB of all forms. You could see from 2020, we were like 4,850 were notified, and 2,687 were confirmed, bacteriological confirmed. So it keep increasing. Could see it goes to 5,820, and so this doesn't reflect that the TB cases or infection is getting spread, but we are covering more. We are discovering more cases. More cases are being reported, and the system gets expanded. We are rolled out to several health facilities, and the reporting rate improved. So there were some cases that were outside, but because of the robust reporting system, we were able to recover all those that were not reported. So DHIS2 integration enabled tracking of TB cases notification, which rose to 95%, 90%, and could go higher than that. And the TB, MDR TB detections grow from 14 cases to around 229, following the gene expert deployment. So now adding more 17 gene experts into the region, so it will improve the case detections and the MDR case notifications. We go next. Yeah, so community service and treatment success, you could see this is what we have explained. But with the Boomer Health Initiative, we have a cluster of households that are supervised by one Boomer Health worker, 40 of them, and they are registered into a family folder. So this family folder is used to screen the TB, HIV cases within the community. However, it is not taking into consideration the mass screening in the community, which we're saying we are going to have a TB standalone as a different modules within the Boomer Health Initiative digital platform, because it's one of the modules that Boomer Health Initiative talks about together with HIV, and the two were not yet added. So the interrupted treatment tracing reduced, a loss to follow up, and community members or community leaders were used to trace up the loss to follow up and bring them back to treatment. So the external quality assurance improve a lot, as TB reference laboratory in the country, and the partners that are supporting TB cases in the country are actually working hand in hand to improve the sample transportations to the national. And you could see the gene expert expanded from one site in 2024 to 64 sites. I mean 2014 to 64 sites in 2024, adding 17 sites this year. It is 2026. We are going to have more than 82 sites. So TV community ambassadors are the patient that recovered, and the good, I mean, the best practices that they have learned, how they have managed their cases. They are in the community, and they are now trying to talk to those that have TB, trying to counsel them, bring them back, and that's actually improved a lot on the case reporting. Go next. What are the lessons learned? So, in all this journey, we learn a lot of things, especially with the governance, data governance. As all of us are aware, the next war is going to be fought on the data, and you could see, especially the fragile country like South Sudan, every dollar coming to South Sudan comes with a system. A good example was, a mass campaign when we were given resources by the Global Fund. One of the UK-based international company came and said they wanted to set up the system to collect the data. But, South Sudan coming up with a health information system policy that called for one database and one systems under one leadership. We were able now to streamline all reporting platforms. So, having a strong data governance framework or data governance structure is one of the best lesson learned that we have learned through. And the system fragmentations, also is one of the lesson learned that we do. Like, as the more system are fragmented, the more the leadership is also fragmented, and the more resources are going parallel through those systems. So it's like people investing on a sideway when they don't want to put money on the main road. So when rain rains and the sideways become submerged underwater, everybody now will come back to the main road that they did not even invest in it. So this is one of the bigger things. And ICT infrastructure gap was also one of the things that hindered the digitization maturity. As we speak now, we have other areas that do not have network for just communication. You find that there's no network. The electricity is so low. It's only Juba that has electricity. Some of the states are having generators. Other facilities are not having anything. So this ICT infrastructure gap was really one of the bigger things. But now the solarization agenda, supported by the Global Fund, is trying to make things work. It's going to be having stable power. There's Starlink, thanks to Elon Musk for coming up with these innovations. Starlink is working everywhere. However, there are still limitations with regard to that styling things. So each is to do with the tablets. Like now, the tablet that were bought by the Global Fund in 2018 are still being used now. What if, this tablet worn out, totally lost the value, and they are not functioning anymore? Given the international financial landscapes, the funding is shrinking and more priorities are coming up. So there's nobody that's going to invest in buying tablets. So we need to really come up with a very robust innovations to see how best we can trying to mitigate such risk. Digital platforms like DHIS2 systems, having DHIS2 systems which worked online, help us get the timely and reliable data on time, and it also, making us have control over our system. So we invested a lot and it also costs us a lot of money in terms of human resource capacity building, and trying to improve the capacity of somebody that has never gone to schools. Some of our data clerk, the some of most of them have primary school educations, which is sorry, yeah. So it's a lot of things, and that's is a big deal. So we have learned that having a digital platform also come with a cost. It's not for free. It's good that you have a platform to report digitally, but the cost that come with it is huge. And if there is no support for that, you can't achieve much. So uh, that's about the digital platforms. When it comes to community integrations, when I talk of BHI, BHI is marking a very good progress, and we are very proud of such initiative. So we will roll it out. It is help us getting data from the grassroots, harmonized data, sending to DHIS. To some are using dual reporting system, paper-based and electronic, paper-based being the backup. But the reporting remain incomplete because it also has a cost associated with that. So you need to provide airtime, you need to provide internet for data synchronization, you need also to support the BHI, those that are, collecting data, need to give them some money for their upkeep, moving around here and there to collect the data. Now, when it comes to sustainability issues, is also one of the big things. Everybody is aware that South Sudan is one of the low resource country in East Africa, where government investment in the healthcare system generally is less than 2%. And entirely our health information system rests on the shoulders of the donors. Assuming that today the donors say we don't want to support the health information system of South Sudan, so everything will come to scratch. So it is going to be a very difficult thing. So we are trying now to advocate and say there should be an investment for digital health in general, where health information system is part of it, and that at least we are moving an inch now with that advocacy, and we look forward to the new leadership of NPHI, National Public Health Institutes, that has been established currently, and the database and the monitoring and evaluations are going to be part of that. So we'll also see how best it will help us there. Next. Yes. So these are the some of the recommendations. We need to increase domestic in financing in the health information systems. Trying to streamline, we need to streamline the reporting systems. We have started with ATBR. We come to EWAS. We are going now to CODA. We move to EWAS. From EWAS now we are going to laboratory information system. So we wanted to bring all this pragmatic system under one roof. So where the integration is not possible, we do interoperability. We allow them to still use their systems and give us what we want at the end of the day. So it's expanding the has infrastructure, ICT infrastructure. So something to do with the provision of reliable internet, power connectivity, purchasing computers, and the rest. So uh, it's very important to have all these things to expand the ICT infrastructure, and the capacity building need to be institutionalized. So making it institutionalize it, like establishing some structured health information system training where people will be get enrolled, although some of them are nurses and all this, and they enroll for this course, it will help them now become a data clerks and also know how best they can be recording all these things. Uh, Community health information system integrations, the BHI is going to be integrated, to include other diseases, but the current structure is already built on DHIS2, and visualizing the data coming from the community or the dashboards and in the DHIS too. And the Minister of Health is already taking a lot of decision with regard to that. So creating some strong feedback mechanism where health community, health facilities, community volunteers, and the national ministry, state level, and county should get and give feedback with the strict timelines. So these are some of the recommendations that we put forward, and trying to look forward to ADC instead of ADC being a platform that bring everybody to showcase. We also need ADC to be a platform for resource mobilizations to invest in health information system, make a lot of advocacy meetings with the leaders, because without data there is nothing you can plan on. So data is very important, and if you don't invest in it you will not get anything. So this is a call that need to go out through ADC, and have that commitment to support the local initiatives if there are local initiatives in the country, like Helena having in-country health informatic associations, supporting them to come up with data prioritization and how best they can come up with a system that can harmonize the health data across all interventions. Next. Yeah. This thing was not done by Minister of Health alone. There were several partners that supported the WHO, UNICEF, UNDP, CORAIDS, and the rest. So we got this support, and we are thankful to our partners that work with us through this journey. And South Sudan Minister of Health is looking forward to partner with ADC further, and also use ADC platform to advocate for more, and see how best we can improve the health information system further. To this point, I would say thank you so much, colleagues, for the opportunity to listen to South Sudan health information system journey from paper-based to the digital system. Thank you so much, Nora. Much appreciation from South Sudan. We really appreciate your work, and we wish you more years ahead of you to also do good things to us. Thank you so much.
Yes, my friend, thank you for that very good presentation. And you've not only given us the case study, but you have also gone through the motions from the beginning up to where we are. And we are so pleased to see something like that coming up. I think at this juncture, we would like to let me get back to Isabella. How many more minutes can we entertain some questions? Already we can see some questions on the chat. And like, does South Sudan Ministry of Health have a data governance policy? We also have others which are internal, like what is the qualification of data clerks? I think some of those ones, I think Matur can pass them very quickly. But then I'm looking for any hands raised, so I'm not seeing any. Dr. Isabella, what is your take now?
Yeah, we have close to 25 minutes. So we can allow Matu to answer to what is on the chat. And I see also other hands. I see Mark hand is up. Back to you, Chair.
Yes, yeah. Matru, you have two questions, and then Mark can ask.
Okay, with the question that have been posted in the chat box, I have a question on data governance. We South Sudan data governance is so broader, as now we have National Communication Authority that is overall institution that is tasked with the data governance. But with regard to health data governance, we have health information system policy that is governing the conduct of health information system, how data is collected, who should collect it, and how it should be stored. So that policy is available, and we also have a strategy, health information system strategy up to 2027. Also outline how we can improve the health information system further to be able now to meet the need of all stakeholders. So we realized that people set up their own system when the current system is not providing their needs. So we came up with a strategy to really improve the systems and be able now to account to all our partners in the country. With the qualification of data clerk, with South Sudan being one of the countries in Africa with a very low literacy rate, uh, South Sudan embarked on a task shifting policy where those that have enrolled as nurses or midwives are shifted to be data clerks. Some who have undergone several trainings as community health workers in the past, starting from 6 months to 9 months, are now working as a data clerk. Although they don't have formal educations, like they have gone to the university or they have gone to secondary school, some of them, through trainings and experience, improved and they got some certifications like courses, online courses with the health information system online and the rest. So the main qualifications of data clerk, most of them are diploma holders, especially in the nursing or midwife or clinical medicines. Some of them have diploma in social sciences that have done business administrations and all this. So they shifted from being in those fields to being data clerks. So that's what I can say for now. I haven't seen. Are there links to the case study available now? Yes, I think the case study is with the ADC secretariats. Isabella can answer that. And so that means South Sudan has no health records officers. Yes, there is nobody designated as a health record officer, but we have M&Es. We call them M&Es or health information system officers. So myself and other colleague have, started to come up with some trainings on health record management. And the University of Juba, under the School of Public Health, they are about to establish a Department of Health Informatics. And that's where I think the health record officers will be trained and graduated. Again, with the economic hardship of South Sudan, it is also very difficult to absorb them. And also with the public service definitions, the health records are not properly defined in our public health employment. Public employment or public sector employment in the country. You either be an IT or you are a public health officer. So being a health informatician is not that defined. And the recruitment is based on the entering grades. If you are a graduate, you are just observing at grade 9, regardless of qualification you have. You just be in that grade. Thank you.
Somebody has dropped his hand. I don't know whether it is intentional, but it came off by mistake. Mark, now we have. Mark, did you still have your hand up or you changed?
Thank you. Thank you, everyone. Apologies. I actually opened up a WHO browser trying to share a link to the Global Health Facility Data Initiative, and it crashed my system. So I dropped off the call. But thank you very much for the presentation and congratulations on the work that you've been doing. I'd asked the question with regards to the data governance policy because, I'm running the Health Sites Digital Public Good, which is building a baseline of health facility data with OpenStreetMap. And what we are proposing and advocating for, along with WHO, is the sharing of baseline health facility data attributes in the form of the name, the type, the geo coordinates, and whether the facility is operational or not, under an open data license, which is consistent with OpenStreetMap. So this would be the ODBL data license. And the governance policy essentially would specify that. So this is a decision that the governance team would make within the Ministry of Health, where they would say, we are going to share this data, but we're not going to share that data. And the data that we do share will be made available under a specific data license, and we'll specify that in the document so that other stakeholders can see it. And because the reason for that is that then gives the opportunity for the crowd and MSF and others to share health facility data with the Ministry of Health, whose responsibility it is to manage that sovereign wealth for South Sudan. And so that was the one question I had. And then the other point I just wanted to confirm, and thank you for bringing it up, which was the need for improved data stewardship around the Ministry of Health. And that has been our mission in Senegal, where I also shared the paper to the work that we've been doing with the Ministry of Health in Senegal, is to build up expertise, geospatial expertise, human-centered design, with individuals who are close to the facilities and understand the context and the challenges. So apologies that I haven't. My real question was regarding the data governance policy. But thank you very much for the presentation. Over.
Yeah, thank you very much for that. I see Costas has his hand up. I assume Matu doesn't need to comment on the data governance because he had said something on it. Cosmas, please.
Thank you, Dr. Ayub Manya, and thanks to the South Sudan team for this very great presentation. It is quite enlightening, and we are great that the HDC community has been able to avail this to us as countries to learn from each other. I just had some few questions for clarifications. Probably I missed them in the presentations. One was around the data governance, but then my question was specifically regarding legislation. I wanted to know if South Sudan has any legislative act of parliament that govern health data, and whether they have also legislation around data protection. It's quite related to what the colleague has just inquired. So wanted to know if there's a specific legislation governing health data. And then also, given the progress they have made in the country in terms of the scale up of the digital transformation, I would like to know whether within their Ministry of Health, they have dedicated team in charge of ICT. I know a number of countries borrow this service from the counterpart Ministry of ICT. So would be glad to understand the linkages between the Ministry of Health and Ministry of ICT. Then the third question is, or clarification I would need them to provide. I've seen the growth in terms of the reporting rate, which is quite commendable. I just wanted to also appreciate by hearing from them how they have addressed challenges to do with the private sector reporting. I would like to know in particular, are the reporting rate from the private health facilities good enough to the national standard, or are they having any challenges in relation to that? But more importantly, even within the public sector, I'm keen to understand also the reporting rate from the tertiary hospitals. In my country, Kenya, I've seen a bit of challenge when we have, where we have tertiary hospitals reporting rate to the main DHIS2 platform, a little bit weak and a bit suboptimal. So if they could clarify how they're addressing that, I think would also add a lot of value to us as country in terms of how we can strengthen our systems learning from theirs. Thank you, Dr. Ayub, and back to you.
In the absence of any other hand, maybe I should now allow Matu to respond to those majorly two questions: Data Protection Act, and then legislation on governance, and also the private sector. He didn't tell us whether we have a robust private sector in South Sudan. Over to you, Matu.
Thank you, Cosma. I think I appreciate all comments, stuff from Mark to yourself. just to be precise, there is no legislations that govern data, health data in the country, but we have the overall act. We call it Computer in Use and Cyber Security Act. It was signed this year, and it is out there. So that's the only legislation that we have. It was signed last 2 months by the president. It's the act that is governing all this. However, with regard to health data, we have health information system policy. It's the one that is talking about how to manage the health data. So it's a tailored policy at the Minister of Health level, approved by the senior management of the Minister of Health. But in the meantime, we are going to have a particular for health data governance framework, which will be in line with the African Union data governance framework. So we are working on it now. But because of lack of resources, most of our meetings are constrained. We are not meeting regularly to discuss all these issues. With regard to ICT team, yes, in the past, all spending agents were seconded ICT personnel from Ministry of Information. But of recent, with the high turnover of government officials, you would find, a minister is appointing someone within the Ministry of Health to be in charge of ICT. But now there is two major units within our Ministry of Health. The ICT team is separate, looking at overhaul of ICT infrastructure in the Ministry of Health. And the team that I'm heading is just managing our DHIS2 system, our server, and having control over the data here. So the ICT unit is not my concern of the data that we have. Most of the ICT equipment that we have are bought by the partners. And when they break down, are services by the partners that bought them. So this made us, totally independent, trying to depend and relying on the donations and all this, something that is very unfortunate. So the Minister of Health was planning to do something about it, but because of the economic hardship that the country is undergoing, it's really difficult. But inshallah, in the coming years, as things improved, there's going to be an independence of such thing. With regard to public health facility, is something very unfortunate, Cosma. We are not collecting data from the private facility. We have only two major, only two private facilities that are reporting now, and they are only reporting in the line of TB and HIV. So we are coming up with a lot of initiative, like in next month, the last week of May, we are going to have a symposiums. The Malaria Consortium, together with South Sudan Health Informatic Associations, are going to conduct a symposium that bring together the private facilities and the public facilities, and the management of both public and the private sit together to discuss the issue of private data. So to that now, there's going to be a communique issued on how best the data will be shared. But I can attest to you that most of our private facilities are having a robust reporting systems. They have all EMR. If you go to major hospital in the country, they have EMR. So it's just a matter of assessing the EMR and trying to do interoperability through API and see how best they can integrate. The private facilities are collecting more data than we collect. So we just need to just get what we want from the system and leave the rest to them. So that's it. As now, the private facility data is still at large. It's not under our control. And we are trying now to come up with a mechanism of trying to get a hold of site data. Yeah, thanks.
Yeah, thank you for those remarks. And I see quite a number of questions on the chat, which I think you can understand. And there's somebody who is asking a question, a very simple question, whether South Sudan is willing to collaborate with neighbors. Maybe I think that's a hard question. Is South Sudan open to collaborate with the residents from other countries to help strengthen HIS? Maybe quietly I can say, yes, I worked there and I'm from another country. I'm talking like this as I wait for any other hand. Otherwise, we should be.
I'm seeing Mark hands up.
Okay. then my eyes are not good. Go on, Mark.
Okay, thank you, Isabella. My question was, what's the relationship with UNICEF in terms of health facility data? How do they share that data with the Ministry of Health? Because my sense is that during COVID and other events that have happened over the years, WHO and UNICEF and the World Food Programme and others are engaged to support the logistics of medical supplies distribution to priority facilities. And so is that validated data shared with the Ministry of Health? And I'm curious just to understand how that data is shared and made available. Thank you. Over.
Yeah, I think thanks Mark for that questions. UNICEF is a principal recipient of both Global Fund resources and the Health Sector Transformation Project. Is a major project that was intended to support 1,158 health facilities. Is a multi-donor project supported by World Bank. So UNICEF is not collecting data. They're just supporting us, and it is us collecting the data. So UNICEF is not having its own systems. So because of the COVID-19 came as an emergency, is an outbreak, our system, like other systems, were not prepared for such outbreak. So people were using the available tool to collect the data. And thus we end up using COBO, okay, like ODK to collect the data. So that data now is still at large, is still being managed is still managed by WHO, and we are now planning to transfer that COVID data to the DHIS too. But because this interoperability or integrations or data migration require resources, we have not yet started there because there is no resource to support such data migration. And it's a huge data. It's a very huge data, and it requires us to mobilize a significant amount of resources to make that. So in short, UNICEF is supporting our health care provisions. The data is collected by our data clerk. UNICEF is just paying them resources. All right, so that's it.
Thank you.
Yeah. With Kelvin, yes, you can collaborate. We are open up for collaborations. If you wanted to come and support us, you are much welcome. And you support us on how to strengthen the HIS in South Sudan. Thank you.
Yeah, thank you. That has been an exciting moment. I think I would like to hand over to Secretariat, because I don't see any other hand, to give us the final comments and any other way forward on, or whether we expect another one coming soon. Over to Isabella and it's called Siri Bandana. Hey, how do you, I've been with, it's a hard name, Bandula.
Bandula Siribadana. So anyway, thank you very much, Dr. Manya. Let me take this opportunity to appreciate Matur here from South Sudan. Appreciate the partners who worked with the team to develop the case study. Appreciate all of you for listening and also the active participation. Just to say that HDC offers a platform to anyone who would want to host a webinar. We are ready, just let us know the topic and we can slot you. South Sudan is also willing to come back and present on, I think it's use of data quality that has been piloted in one of the states. That's Matur and Malaria Consortium, and we shall also be inviting you. We have other exciting webinars from other countries. We shall be hosting Lao soon. We shall also be hosting Malawi, who are also here with us, and also looking forward to hosting you in any of the topics. So we really do appreciate, and let me hand over to Pandula if you would want to say something. Thank you so much, our co-chair, for leading us in this process. Thank you, and bye.
Thank you very much,
Pandula?
Isabella. Thanks, Isabella. I was very disappointed that I cannot still pronounce my name after 3 or 4 years being together. Anyway, it was a great webinar. Thank you very much, Matur and the team. I think this is exactly what we want to do through the HDC sharing of data use cases, experiences, the evolution of RHIS systems in countries, and that sharing of knowledge goes a long way in terms of supporting many others and also triggering partnerships and collaborations. I think that's what HDC is here to facilitate. I think with that, Isabella, I think we can close off the session. Again, thanks to Ayub also for moderating the discussions and everyone for your contributions. So we'll see you next time with another webinar of the series of RHIS data use. Thank you very much.
Okay, thank you and bye.
Thank you.
Thank you. Thank you
Bye,
so much.
everyone.
Thank you very much.